Erectile dysfunction is one of the most common conditions that can afflict a man. It occurs more commonly with age, and 1/3 of men will develop erectile dysfunction at some point in their life. One out of 4 men who present to the clinic with erectile dysfunction are under the age of 35. There are various treatment options for erectile dysfunction. The first option tends to be oral therapy, and this can include Viagra, Cialis, Levitra, or Stendra, as well as all the generic variations of these medications. For patients with psychogenic erectile dysfunction, we are fortunate to have a sex therapist who works with us, and we're able to refer these patients to them. We also always check testosterone levels in these patients, and when the testosterone levels are low, testosterone supplementation might help improve the sexual function as well as the erectile capacity. In men who are not responsive to pills, what we usually proceed with is an ultrasound of the penis after injection of a medication into the penis to allow for a strong erection. This ultrasound allows us to know what is happening in the penis. Is the problem with the penis that the blood is not flowing well enough into the penis, which is due to decreased arterial volume of blood, or is that because the blood is leaking out of the penis, which we call venous leakage? Regardless of the findings, the next step after the oral pills would be the injection of a medication into the side of the penis just before sex to allow for an erection. These are called intracavernosal injections. There are various iterations of these medications, but the most commonly used medication is called Trimix and is available through compounding pharmacies. Other options include a gel or suppository that can be placed through the urethra to allow for an erection, as well as vacuum erection devices. These are hollow cylinders that are placed on the outside of the penis. A patient presses a button and it allows for suction and therefore bringing blood into the penis, at which point a ring is placed on the base of the penis to keep the blood in the penis. Finally, in patients who are not responsive to less invasive options, the best option is placement of an inflatable penile prosthesis. The inflatable penile prosthesis at first sounds like a crazy idea, but this is a device that was developed in 1973, so it has about 50 years of history behind it. It's basically a minimally invasive surgery in which we make a small incision, which is about 1 inch wide, at the base of the penis where it joins the scrotum. Through that small incision, we are going to place 2 cylinders in the penis. These cylinders are made of silicone and they're filled with water. We're also going to place a little pump between the testicles and the scrotum, as well as a balloon of water inside the abdomen. All of this is placed through that little small incision at the base of the penis. The entire device is a hydraulic system that is completely concealed inside the body, so nobody will know that the patient has an implant or a penile implant inside their body. When a patient wants to have sex, he's going to grab the pump between the testicles and the scrotum, and he's going to apply multiple pumps. It usually takes anywhere between 10 to 15 pumps. And what happens when he applies the pump, the water will go from the reservoir in the belly into the penis, and then the penis will get rigid. As there is a one-way valve on the cylinders, once the water is inside the cylinders, the patient will get an erection that he can keep for as long as he wants. Once he's done, on the same pump that is in the scrotum, there is a little deflation button. The patient will press the deflation button and the water will go back in the opposite direction from the cylinders in the penis into the reservoir in the abdomen, and the erection goes down. And therefore, it becomes completely concealed. The patient can continue wearing the same clothes he usually wears, and nobody will know that he has an implant. The implant is a surgery that takes about 45 minutes. It's outpatient, and the patient can go home the same day after surgery. The recovery is pretty quick. We have, along with a group in Pennsylvania, developed a pain protocol that allows our patients not to require any narcotics after surgery. Patients are usually able to go back to work within 1 or 2 weeks after surgery, but they are not able to have intercourse for 6 weeks after surgery while allowing for healing. After the surgery, sensation, orgasms, ejaculations, urination, all of this remains the same, and there is absolutely no change. Similarly, for the partners, there will be absolutely no difference in terms of sensation of having sex with a rigid erection or with an inflated device, as the device is under multiple layers of skin. There are complications with an implant. There is a risk of infection of the device, which is about 1%, and is similar to the infection rates that are seen with hip and knee replacements. There's also a risk of a mechanical device malfunction, so if any of the pieces of the implant stop working, that's about 3% over a lifetime of 15 years. On average, most devices survive about 20 years. So for most patients, they either get 1 implant and they're done for life, or they get 1 implant and possibly 1 revision down the road. Finally, as I said earlier, the pain after the surgery is very well tolerated, but about 1% of patients Overall, mostly diabetic patients who have severe neuropathy will have chronic discomfort after the implant, but that is not common and most of the time is very well tolerated.